First speaker, Professor David Weber, is board certified in internal medicine, infectious disease, critical care medicine, and preventative medicine. His research career has focused on healthcare-associated infections, antibiotic stewardship, new and emerging diseases, and vaccine implementation. He has published over 475 peer-reviewed scientific papers. And I welcome Professor David Weber. I'll hand the presentation to you, Professor Weber.
I want to thank all of you for taking a time out from what I know is a busy day to hear this presentation. As you can see here, we're going to be talking about different guidelines, ACIPC, ASUM, as well as the CDC guidelines for disinfection and sterilization, for which I was a co-author. And both of these form the standards, and these standards are important for hospital accreditation. They're important for maintaining safety for our patients, and they provide a standard of care. As you can see here, we have a picture of an ultrasound probe. Probes are classified as reusable medical devices. They must be disinfected between patients to prevent carryover of microorganisms from one patient to another. The level of disinfection required depends on the cross-infection risk. This is the Spaulding classification. It's been in use for a number of decades. It forms the basis for how we provide disinfection. It has been modified over the years. Basically, we classify infection risk as low, medium, and high. We have non-critical items, that is a probe or another device that comes in contact with intact skin, for which we use low-level disinfection. We have a semi-critical device, that is a probe or another device that comes into contact with non-intact skin or a mucous membrane, for which we use high-level disinfection. And finally, we have a critical device, a probe or another device that comes into contact with tissue or the bloodstream. Those should ideally be sterilized, but if that's not possible, they should be high-level disinfected and placed inside a sterile cover, if placed into a sterile field, used in a sterile field to help prevent contamination. Again, the Spaulding classification, we have the levels of disinfection. We'll have different activities against different pathogens. As you can see in this hierarchy, lipid envelope viruses, which include SARS-CoV-2, the most easily inactivated, followed by vegetative bacteria, and low-level disinfection will eliminate those. Next, we have fungi, small non-lipid, non-enveloped viruses such as the norovirus, HPV. Then we have mycobacteria, and high-level disinfection will eliminate those. And finally, we have bacterial spores, and sterilization will eliminate those. However, I should say low-level disinfection will in fact eliminate some fungi, and high-level disinfection will in fact eliminate some spores. It's just that it cannot be guaranteed to eliminate all the spores. And again, non-critical devices we use low-level disinfectants. Semi-critical devices, we use high-level disinfectants, and critical devices are sterile, which means that all viable microorganisms have been destroyed. Now, why is high-level disinfection of endocavity ultrasound probes necessary? Well, of course, we see that those probes are clearly contaminated during use when they touch mucous membranes, such as in the anus, the vagina, or the esophagus. In addition, the handles of the probes are often become contaminated, although they don't touch the mucous membrane directly, but they're often contaminated by the hands of the provider as they touch the probe in different locations. Research shows that surface probe contamination, about 80% of probe handles have residual pathogens, including MRSA. And again, that's because while the probe handle itself may not touch the mucous membrane, the provider will be touching other parts of the probe and then the handle, or they may rest it on a surface that's contaminated. We know that 13%, by the way, of cavity covers, probe covers have tears. Pre and post transvaginal ultrasound examination. So while it's certainly recommended to always use a probe cover by itself does not guarantee that the underlying probe will not become contaminated, either because of the tear in the cover or because in the process of removing the cover, one contaminates the underlying probe. 62% of transducer cables, in fact, showed microbial contamination as well. And in terms of the organisms causing contamination, not surprising, they represent skin organisms like Staphylococcus and Streptococcus. And then they represent organisms that you would find in the vagina or rectum, such as enteric gram-negative rods, such as Klebsiella and Enterobacter, but also non-enteric organisms such as Pseudomonas and Acinetobacter. Again, research shows that endocavity probe contamination occurs despite a probe cover plus low-level disinfection. Before disinfection, roughly 34% of transvaginal probes had the prevalence of bacterial contamination after the probe sheath was removed for the reasons we've already stated. A meta-analysis found procedures using disinfection wipes, contamination remained up to 13% for pathogenic organisms and pathogenic viruses on the endocavity probe. That occurs for two reasons. One, the low-level disinfectant may not be active against the pathogen. And second, when you're wiping a probe, you may not have contact with all the surfaces. In addition, research shows probes contaminated. Additional research from Hong Kong, 7.5% were HPV positive, human papillomavirus positive. Again, this is a non-envelope virus and would not be susceptible to low-level disinfectants. In France, again, in studies, again, showing 3 to roughly 3% are HPV positive there. Spain and France, similar studies, again, showing substantial amounts of HPV positivity, 5 to 15%. And of course, HPV remaining on the probe does represent a substantial risk of carrying HPV from one patient to the next and leading to HPV infection. So a retrospective study in 2010 to 2016 revealed an increase in infection risk in the 30 days following transvaginal ultrasound. These patients were found to be 41% at greater risk and a 21% greater risk of needing antibiotic prescriptions in the 30 days following transvaginal ultrasound, demonstrating that the mere presence of pathogens actually does lead to real infections. This is very important to consider. Now, this is a study, Infection Risks of Low-Level Disinfection Endocavity Probes, a computer model. I was a co-author of this study. The goal was to assess risk for a transmission of infection via endorectal or vaginal ultrasound probes using probe covers and low-level disinfection. The model was based on all cases in France. We used stochastic Monte Carlo simulation. The results, as you can see from the right, is that use of probe covers plus low-level disinfection would be estimated to result in 40 HIV new infections and 1,600 to 15,000 other viral diseases. And therefore, adherence to CDC disinfection guidelines is critical. And as you can see in there, of particular importance are HPV, but also listed are HBV, HCV, CMV, and other infecting agents. So if you think compliance is expensive, try non-compliance in the United States and certainly in other places in the world. There have been lawsuits claiming that the patient infection has resulted from use of low-level disinfection, and therefore patients became infected. And therefore, those lawsuits have led to payments and, of course, potential stigmatization of the providers as well. And again, our goal is to use ultrasound safely and protect our patients. So why is high-level disinfection of ultrasound probe is necessary? As with this issue, but with everything we do in healthcare, prevention is always better than treatment or cure. And so healthcare facilities should follow evidence-based guidelines that mitigate risk with the use of ultrasound probes. And up to 70% of healthcare infections, associated infections, are preventable using these existing infection control prevention guidelines. So in terms of probes, infections transmission occurs due to 1, inadequate cleaning, and or 2, improper selection, use of a disinfecting agent, and or 3, failure to follow recommended cleaning and disinfection procedures. So what do we need to do here? First, we need to use 3 steps, all based on what I've just said, to reduce contamination risk. First, thorough cleaning always precedes disinfection, not just on endocavity probes, but for all other devices. Second, we should be using high-level disinfection after thorough cleaning. And finally, we should have a probe covered with a single-use probe cover before the next patient examination. And as you can see, the guide to ultrasound cleaning there, again, use of transducer covers are recommended when you're touching non-intact skin, amniocentesis or suprapubic bladder taps, transvaginal probes as well. And high-level disinfection is recommended for all but use of an external probe on intact skin. So now we have a polling question. Does your facility complete all 3 steps? 1, clean, 2, disinfect, 3, use probe covers before using an ultrasound probe that is classified as a semi-critical or critical item on the next patient. Please select yes, no, or not sure.
The results from our live poll, we have 55% yes, 14% have said no, and 31% have said not sure.
Thank you very much. That is much appreciated. And so we see we have many of you are doing what is recommended, others are not. So certainly an excellent teaching point to take back to your facilities. So again, this is a so-called Swiss cheese model of medical errors. You see that all the holes have to line up to lead to a medical error, or in this case, a patient infection. 3 steps to reduce contamination risk: cleaning, which removes 2 to 4 logs of organisms; disinfection, high-level disinfection, removes 5 to 6 logs. We've taken the lower numbers here. And a probe cover generally prevents about 2 log reduction, causes in there. You add up the 1, 2, 3, and you get the total log reduction of organisms, which in this case would be 10 to the 9th. And so it's highly unlikely, and this is for specifically HPV, you would using these 3 steps would lead to any patient-to-patient transmission of HPV. So again, the 3 steps to reduce contamination. Now we're going to talk about other methods of doing this. One is the use of ultraviolet C irradiation. It's an effective disinfection method to inactivate human papillomavirus. As you can see here, we're looking specifically at HPV 16 and HPV 18, 2 of the HPV types that responsible for cervical vaginal cancers. And in this case, the automated antigermix S1 and Hypernova Cronus device showed excellent efficacy against both HPV 16 and HPV 18, where OPA, a chemical disinfectant, showed minimal efficacy. These results suggest that healthcare facilities using endocavity probe ultrasounds need to strongly consider the disinfection methods they use and whether they're effective against HPV. Again, 3 steps to reduce contamination risk, as we can see here, are cleaning, followed by high-level or low-level disinfection, and then use of a condom cover or not. And what this clearly shows is the use of thorough cleaning followed by UVC irradiation for high-level disinfection with use of a condom cover gives you by far the greatest log kill and therefore the greatest margin of safety for patients to prevent patient-to-patient transmission of pathogenic microbes. Again, the 3 steps for contamination risk you can see here. Cleaning, low-level disinfection, and probe covers reduce the log counts by 99.9%, whereas cleaning followed by high-level disinfection and an appropriate probe cover gives you substantially, by many logs, much better inactivation of HPV, substantially decreases the risk to essentially near zero of HPV and transmission between patients. What to consider in selecting a high-level disinfectant: 4 considerations. Workflow, you obviously need to consider what's the best for your staff and most efficient. That allows you to rapidly disinfect a probe between patients, so you maximize patient throughput. Traceability, you certainly would like to have records kept so that you know that each probe was properly disinfected, and ideally a paper trail. Automation provides further benefits of a manual disinfection. Anything that can take the human out of the step decreases the likelihood of human error, and so allowing the machine to do this in an automated file clearly reduces the likelihood of staff errors. And finally, a validation to make sure you have a system which actually validates that high-level disinfection occurred. So in conclusion, evidence-based research is a major driver in changing clinical practice. And as I've already showed you, the guidelines as well as the clinical data suggest the need for cleaning, high-level disinfection, and probe covers. And there is substantial evidence that this benefits the patient. Not all research is of sufficient quality to inform clinical decision-making. You need to critically assess the evidence before you can use it, although the guidelines sort of help you with that by having experts and, in fact, assess that information. Three major aspects of evidence to consider. Validity, can you trust it in terms of your disinfectant method? Are the results clinically important? And certainly we want to protect our patients. And applicability, can you apply it to your patient? I hope I've shown you both from the evidence and the guidelines the needs for cleaning, high-level disinfection and probe covers, as well as the utility and advantages of using UVC high-level disinfection. Thank you very much.
Thank you, Professor Weber. Before we move on to our next speaker, here is our second polling question. To answer the following question, please click on the live poll button, which is at the bottom of your screen. It is the sixth button from the right. Click on that button and you can make your selection. The question is, are you aware of the recommendations from the College of Intensive Care Medicine Ultrasound Special Interest Group, USIG, in the prevention of pathogen transmission during ultrasound use in the intensive care unit? Please answer yes, no, or not sure.